Professor Chandy, welcome to Bangladesh. I know that you are involved in treatment of blood cancer for several years in a country like India, where the economic condition is not good. And the same way, Bangladesh is also a poor country. So you have a vast experience in managing blood cancer patients with poor economic background. So do you think that in Bangladesh also it is possible to manage blood cancers with this poor background?
I think all people with blood cancer are entitled to a diagnosis. So at least that must be provided in countries with limited resources. And providing that is not too difficult. You need to have a full blood count, you need to have a bone marrow examination, and you need to have special stains. About 70 to 80% of blood cancer can be comprehensively diagnosed with just a blood film, a bone marrow, and special stains. For about 10 to 15% of patients, you need additional help with immunophenotyping, cytogenetics, and molecular testing. That is expensive, but if that's possible, then you at least have a comprehensive diagnosis. Once you've made a diagnosis, then you have to make a choice. If it's a young child with acute lymphatic leukemia, with a fairly simple protocol, you have a 70 to 80% chance of treating this disease adequately. So I would say that even in developing countries where the family is motivated and will be regular with treatment, one should offer a treatment for acute lymphatic leukemia. For patients with chronic myeloid leukemia, obviously there is good treatment, and the treatment is with imatinib. The generic imatinib produced in Bangladesh and in India, I believe, is probably just as good as Glivec, and therefore these patients should be put on imatinib. For the patients with acute myeloid leukemia, where there are no resources, it is extremely difficult, and even in my institution, we do not treat a person with acute myeloid leukemia who does not have the resources. These patients are often palliated with just hydroxyurea. Having a bone marrow transplant program, even in a poor country, makes sense, because even in a poor country there are rich people, and these rich people need transplantation. And if the transplant is done in your own country, it will save a lot of resources, it will provide a facility for the patient. And in my own center, we are able to generate resources with a bone marrow transplant program from the rich patients, which is used to subsidize the cost for poor patients.
Now, you have visited Bangladesh on several occasions, and I believe that you understand the problems of Bangladesh, not only in the economic field, but also in the organizational affair, in the infrastructure development affairs. So with these backgrounds, do you think that we can manage acute leukemia or similar blood cancers with a hope of cure or with a hope of meaningful continuation of life?
I have written a paper published in Pediatric Oncology on treating leukemia in a three-tier society. And Bangladesh is a three-tier society. There are about 5% of your patients who can afford to have the best treatment available anywhere in the world. And those patients should be given the appropriate treatment. You have a rapidly expanding middle class, like India, constituting 20% of people. These people also may be able to afford reasonably good treatment. For the 70% of patients who are totally dependent on government for their treatment, you will have to draw certain distinctions and say only a low-risk acute lymphatic leukemia can be treated. A person with Philadelphia positive acute lymphatic leukemia, we will make a diagnosis, but we can't do anything further. For acute myeloid leukemia, you will again have to make a hard choice and say that yes, in Bangladesh, we cannot afford to treat 70% of our patients with acute myeloid leukemia. Those are the difficult choices that has to be made till the country has more resources.
Now, two more issues. The one issue in the West, we know that there is a sense of cooperation among the poor countries there, South American countries, and they cooperate with each other and develop and manage the patients with a kind of acceptance. So, do you think that we can develop a cooperation with our own people and with India? Say, for example, with the Institute, can we establish a cooperation so that we can develop our management to an...
I think that is possible, that there are joint protocols which are worked out, and you cite South America as a good example, which is true. They have put their act together, and they have common protocols for many diseases, including acute promyelocytic leukemia. And that's one disease where we can do something about, because arsenic trioxide, in our experience, produces remission in 70% of patients. And in the low-risk APML, patient can be cured. Therefore, I would say yes, we would use arsenic trioxide for treatment in a person with acute promyelocytic leukemia. And I do believe that this sort of cooperation is possible.
And the other issue that, as we mentioned previously, that some patients are not capable of treating because neither they can afford nor the government is capable of helping them. But palliation has a role in treating them. So probably no patient can be denied of management from physicians.
Yes.
So developing palliative care in managing blood cancers also is a field that you are doing in your center. So do you think that we should look into that aspect also in our country, so that at least who cannot afford treatment, full treatment, we can afford some form of palliation to them?
Absolutely, I agree that where you cannot treat with an appropriate curative protocol, one should at least minimize suffering, and that is the role of the physician. And therefore, having good palliative care programs which are properly structured is very important for a developing country.